Bugün ben
bipolar disorder and patients planning pregnancy, bipolar patients planning pregnancy and approach to those shall be tackled now. I'm really excited because being together with such experts is really important for me. So I think I'm just an apprentice here at this point. Bipolar disorder and approach to bipolar disorder patients during pregnancy is really important because the risks that we've just talked about can be evaluated in this manner. If the patient comes to us saying that she's planning for a pregnancy, there is something which has been believed wrongly until now. Pregnancy is preventive against psychiatric disorders is the wrong belief, because especially in bipolar disorder, recurrence rates are equal to those of the non-pregnant women, and the recent trials show that particularly when the drugs are discontinued, the risk of relapse even increases. Manic and hypomanic episodes in bipolar women frequently are associated with high-risk sexual activity, and most of the pregnant women, unfortunately, do not get the diagnosis of bipolar treatment until they have babies. 70% of those women, approximately 70% of those women, experience at least one episode of their diseases during their pregnancy period. Therefore, clinicians should discuss plans for conception with all women with bipolar disorders who are at the childbearing age. So pregnancy-related plans and ideas should definitely be discussed. This is really important. It is important to discuss those in advance, because if this is discussed before pregnancy, then in that situation, the negative effects of pregnancy can be prevented. I mean, if this is established, identified, and discussed, then the pregnancy-related negative outcomes can be prevented or be reduced, at least reduced. So, bipolar disorders diagnosis before pregnancy makes it easy for the drugs to be continued or discontinued, which means it gives options for different treatment modalities as well. In bipolar disorder, there are special difficulties for the woman herself and for the relatives and also for the doctors. Women and their families have to go through difficulties such as the course and risk of recurrence illness, risk of recurrence of the illness during pregnancy and postpartum periods, and the woman might wonder whether she will be able to take care of the child, and there can be some anxieties about the drugs, fetal tragenicity, and for the clinician, maybe the most important problem is to have an effective non-teratogenic treatment, because the lack of effective non-teratogenic treatment is a problem. The impact of untreated psychiatric illnesses during pregnancy is another problem. If the drug is discontinued suddenly, there is a high risk of relapse, and during pregnancy and conception there might be some negative effects, and evidence-based data on this matter show that these are complicated issues. Of course, the legal liability of the doctor is another important problem. Now, the relatives of the women with bipolar disorder have certain difficulties. We see that those women usually tend to terminate their pregnancies or they avoid their pregnancies. And when information about the potential risks is given to those women. We hear that 37 of the patients do not want any pregnancy at all. And almost half of those women, when asked, have said that a doctor, an obstetrician, when they asked those pregnant women, they did not want to have a baby. They did not want to give birth to the child, they said. And the discontinuation of the existing treatments in bipolar disorder is quite risky. However, potential teratogenicity risk might lead into important reservations and fears on both the doctor and the patients. It causes quite a great deal of stress, and that's an extensive clinical practice. And the drug which is already used is usually discontinued. Therefore, women with bipolar disorder are usually left without any treatment in this period of time. So what do we have to do in that decision-making process? And how can we continue with the treatment? How are we going to decide whether we're going to continue with the treatment or not? When the patient is atypical or before pregnancy, the patient should come to us and the discussion should take place at that stage. Especially the majority of women with bipolar disorder have little insight about the existing treatment. So considering that, if possible, the spouses and family members should be a part of this planning too. Before pregnancy begins, the family of the patient and the clinician should come up with a detailed plan about the potential interventions which might take place, and if there is recurrence and if the symptoms emerge, people should know what to do. So plans about those should be performed. For example, the effects of the drugs to be used should be discussed, even they're not used right at that moment. So you might consider using an EKT, and if this is the case, this should be discussed with the relatives and the patients themselves. Responsibility about probable risks should be shared with the patient, but at the end of the day, the decision belongs to the patient. Identification of the risk factors firstly require a psychiatric formulation, the history of the patient, the past suicidal initiatives, the existing treatments, responses to treatments, and similar formulations should be taken into account. But the most important thing here is this. I mean, in this story, what we have to take into account is actually this. The response to the previous treatment is very important. The severity of the disease, duration of athemia, I mean, the period which went without any treatment, the time of relapse after medication is discontinued, and time to recover with reintroduction of the medication. These are things to consider, and especially these trials conducted show that the components which are associated with high risk component is the sudden discontinuation of mood stabilizers if there is more than 4 mood episodes, and if the mood episodes exist between the previous deliveries, then these are all problems. The clinician should go through all those, and the clinician should consider the risks and benefits of the drugs which are being used or which are planned to be used in the future for both the patient and the baby. Shall there be a treatment or not? They're both risky. There is no situation without a risk. When the treatment is given, fatal teratogenicity is the most important risk, and poor obstetric outcomes and infant outcomes. Poor infant outcomes might be observed. If no treatment is given, women. Again, many risks are assumed, but this time it looks like they are assuming more of a risk, but fetal teratogenicity is really scary for all of us. A pregnant woman who doesn't receive any treatment might use more drugs and more illegal drugs, and may have other psychiatric problems. There is more risk of a suicide, and the recurrence risk of the patient is higher, especially when the mood stabilizer that is used is discontinued. And also poor outcomes are observed on the pregnant women and the infants, because uncontrollable symptoms have a negative effect on those. The component we should not be neglected is that in the postpartum period the risk of psychiatric problems increase, especially in that period of time. In one of the trials, the data showed that it increases 70-fold when compared to women without any psychiatric previous experiences. And depression risk and manic episode risk also increases in such women. Now, we've considered all those risk factors, and let's say that we find that the pregnant woman is in the low relapse group, so we have to discontinue the drug, but we have to do it slowly. There are two ideas about this. We might discontinue it in 6 weeks or in 15 to 30 days. 6 weeks is a longer period of time before the pregnancy is planned. Before the pregnancy takes place, maybe we might realize this, but the other one gives us more of an opportunity to discontinue the drug. And if it is discontinued in a shorter period of time, the risk rate is going to be quite high. Two options occur while discontinuing. Before pregnancy, the drugs can be discontinued while the pregnancy is just being worked on. It has its pros and cons. The advantage is that we do not know when the woman is going to conceive. The period until conception is going to the time without any drug use. If there is a relapse in that period of time, then we can administer a medicine for that patient, and the period before the relapse is important to us. We can start administering a drug, and if this is the case, time until cure is important to us. In this way, we're going to see both risks clearly, and we're going to plan the pregnancy much better for the upcoming period. So it has advantages in that sense, but it has a disadvantage. The patient will not be experiencing the non-drug period during pregnancy, and that period without any drug administration should coincide with pregnancy if possible, because we know that in bipolar disorder the drugless period increases the recurrence rate, so this period is totally wasted. So this is an important disadvantage. The other method that we can follow while discontinuing the drug is that until the pregnancy is identified, the patient can continue using the drug and can discontinue the drug when the pregnancy is established. It has disadvantages too, and the women in that period of time have irregular menstruation cycles, so it may not be very easy to diagnose the pregnancy. For teratogenic risk, the most important period can be missed, and there will be exposure. The other disadvantage is that since there is need for a sudden discontinuation, the risk of recurrence is going to go up. But the advantage, but this disadvantage can be turned into an advantage in this way. When the patient plans the pregnancy, the drug use can be brought down to the lowest dose. You can continue giving that dose. Of course, there has to be a proper follow-up. Both the patient and the doctor should establish this because we know that the first 3 weeks after pregnancy is not that risky. So that 3-week period is quite critical to us. If the women understands that there is conception and if the menstrual cycle is regular, we're left with only 15 days. And in that period of time, the amount of drug that is already reduced can be gradually discontinued. This also can be turned into an advantage. If the patient has a history of a severe disease, then treatment is going to be more difficult because maybe throughout all trimesters of the disease, this patient will have to use a drug. And the treatment of the patient should not be considered only in terms of fatal and neonatal effects. The tolerability should be considered, the safety should be considered. The general suggestion is that if during the first trimester the drug has to be used by the patient, then it should be brought down to the lowest dosage. If possible, monotherapy should be given. The lowest efficient dosage should be used during monotherapy. Now let's talk about the most extensively used drugs for bipolar disorder, and let's go through their effects. Lithium is the one that is used the most as a mood stabilizer. Some authors recently suggested that they can be used in pregnancy, but some others are avoiding this because, as you know, cardiovascular malformations are really high, and Epstein anomaly has a low relative risk, but the absolute risk, says the speaker, on the contrary, the absolute risk is very low, therefore it can be used, they say. And bad neonatal results might also emerge, like the floppy baby syndrome, hypothyroidism. If we have to use lithium in pregnant women, then we might suggest that between 16th and 18th weeks, the high-resolution ultrasonography and the fetal echocardiogram can be used. Carbamazepine and valproic acid are the other mood stabilizers used. They are more risky when compared with lithium in terms of malformation. Neurochip defects, craniofacial abnormalities, heart defects, and microcephalus might be observed. In both of those, anticonvulsants have been defined. In valproic acid, mental retardation is identified, and neonatal toxicity is high. There are withdrawal symptoms, and the fibrinogen levels are also reduced, so it might increase the predisposition to hemorrhage. These data are coming from the epilepsy patients. There is a suggestion by the American Academy of Neurology here. As for preventive purposes, 3 to 4 milligrams of folic acid can be added to those patients, but how preventive is this? That we do not really know. Carbamazepine has similar risks with valproate, but we have to be very careful about something. Carbamazepine in the first 8 weeks might have severe side effects, so we shouldn't start during pregnancy. We shouldn't start using carbamazepine during pregnancy, and vitamin K deficiency should be another thing to be careful about. Lamotrigine as monotherapy is also is recommended, and it is found to have no association with any major malformations. However, a recent report of the North American Society shows that it increases certain defects. Antipsychotic agents and chlorine thiazines were used in the treatment in slight doses, and a very low risk of malformation was found to be associated. Some other trials find similar results, but we do not use It's in bipolar disorder a lot. Atypical antipsychotics are limited, have limited data about their use during pregnancy. Especially olanzapine and clozapine are things to consider because gestational diabetes risk and weight gain is increased. Antipsychotics, why can we discuss those? If the patient in the first trimester is using a mood stabilizer, and if that is planned to be replaced by another treatment, then antipsychotics can be used. Or if we discontinue the treatment and if there is recurrence and symptoms worsen, then a treatment can be initiated, and instead of mood stabilizers, antipsychotics can be considered. Benzodiazepines are helpful in regulating sleep, and manic recurrences during sleep are prevented in this way. Lorazepam and clonazepam do not related malformations are not reported, but safety of diazepam is controversial because increased risk of oral collapse after first trimester exposure and intrauterine growth retardation are reported. Intrauterine growth retardation is a problem. If we have to use, the high potency compounds may be used because they have shorter half-lives and they have less accumulation in the body, and they are benzodiazepines. But there's benzodiazepines. Neonatal toxicity can be observed in those using benzodiazepines. Impaired temperature regulation, apnea, lower Apgar scores, muscular hypotonia, and failure to feed might be a problem. It should be discontinued before delivery. Motor and developmental retardation is reported in a couple of cases. ECT, especially in severe recurrences, is highly recommended. It has relatively less side effects, and the untreated bipolar disorders risk is higher than that, or the other mood stabilizers to be used have higher risks of teratogenicity, so the risk is really less. Complications related to ECT are rare and temporary. Cardiac arrhythmia has been reported, and it is due to barbiturates and atropine that are used. Uterine contractions are also observed, and in a couple of cases, growth retardation, developmental retardation, and mental retardation are reported in women exposed to ECT. Non-pharmacological treatment options, psychosocial interventions, and compliance to treatment. We can use those in increasing compliance to treatment. Social and professional functions can be improved thanks to those, and it can decrease sleep-related complications. It can prevent relapse, and sleep-related problems can be solved. Moods related problems can be solved. Omega-3 fatty acids and their use have been worked on a lot recently, but about the efficacy, the data are quite low. The data are quite weak. They have no side effects and have positive effects on the brain of the fetus. So 500 milligrams per day is the recommended dose. In the first trimester, let's say we discontinue the drug and we get by. How do we go about it in the following stages? Let's say we go down to the lower doses. Then let's say we're continuing with monotherapy with the lowest dose. What do we have to do in the second and trimester? The second and third trimesters have lower risks of malformation, but they're not very innocent. Identification of early signs of relapse before restart of the medication requires patient's history. If the patient's history includes self-harm, or if there is protracted recovery time, and if there is impaired insight, and if there is evidence that our support system cannot tolerate another episode, then these should be regarded as an early sign. maybe the support systems of the patients are not enough, and maybe an episode to emerge cannot be tolerated. As a result of this, bipolar disorder patients planning to get pregnant can be provided with these recommendations. A general recommendation for treatment of bipolar women it might include those: balanced and accurate information should be given to the patient, such as the treatment options, relative risks, high risk of relapse when discontinuing maintenance medication, and risks to the patient and child of uncontrolled symptoms, the postpartum period without treatment, and the strong genetic loading. Women and their health caregivers should discuss everything during pregnancy and after pregnancy. If a treatment is initiated and if it is continuing, it should be monotherapy, and the most efficient and the lowest dose should be picked. The least teratogenic agents should be picked. The older agents can be used is one of the suggestions, because the efficacy or the side effects of the new agents will be revealed only after a period of time, so the current ones should be preferred as one of the suggested. High potency antipsychotics could be used if needed, but extrapyramidal side effects should be taken into account. If valproate or carbamazepine are being used by the pregnant women, then in the first trimester, their doses should be reduced if possible. One should avoid using those, and if they're being used, then a fatal ECG can be performed. Lamotrigine monotherapy is found to be the first option by some of the authors. In terms of neurochip defects, 4 milligrams per day is found appropriate. We have to finish if you want to get some questions. Omega-3 fatty acids should be considered. ECT can be used in severe cases, and women and their caregivers should plan ahead to ensure adequate social support and assistance with infant care to minimize sleep disruption. A regular support system should be obtained. It is also important to address the consumption of caffeine, nicotine, illicit drugs, and alcohol, as well as poor nutrition, and the general conditions of life should be regulated in the best way possible. Thank you for your patience.